And I also have the power strip underneath me, so if I accidentally hit the power button, I apologize.
He's already threatened.
Yeah,
I have a little button.
Thank you. Where is Patty, or we need to do roll call?
Patty?
Commissioner Barry, can you just speak into
Is this on? Okay. Patty, can we do roll call?
Yes. Commissioner Barry?
Here.
Commissioner Klein? He is not present for the record. Commissioner Yuri?
Here.
Commissioner Wellens?
Here.
Commissioner Gregoire? Here.
Do we have any public comments?
I am noting that we have a quorum and we do not have public comments.
First thing we want to do is approval of minutes from the last meeting. Anybody?
Move approval of May,
May's minutes, yes.
May 30, 2018.
Second, anyone? Second. All in favor?
Aye.
Any opposed? Great. All right, let's just jump right into it and go to the May financial overview, which I believe you have a copy of in front of you. Alan?
Yep. Thank you, Commissioner Barry. For the month of May, we had a net loss from operations of 11.3 and a budget of loss of 12.5, or $1.2 million favorable. And also we were $4.6 million favorable to prior year. On a year-to-date basis, as we've been kind of talking, we finally dug ourselves out of the early hole that we had. And on a net loss from operations, we lost 126 on a budget of 129. And that's year-to-date favorable by 2.6 and $3.9 million better than prior year. For the record, I just wanted to note there's a little bit of significant adjustments that are in the May's number that all net out to be about $1 million favorable pickup for us. There was a settlement that we received for 5.4. We had to true up some of the ACO for our balance sheet purposes. We restructured it, and we're from a conservative approach. We took a little less out of income just to be conservative. We had some net revenue reserves that when we had some turnover in one of the facilities, we had to do an adjustment of 1.6, and then we had some expense reserves pick up that we booked for about $2 million. All of that nets out to if we normalized it, would have been a $12.6 million loss on a $12.4 million budget, or 124 unfavorable.
Alan, if you would, when you go through these, please go to the page number and guide the eyes.
Okay, I'm sorry. Yeah, we're on page 2 of the PowerPoint presentation. I apologize about that. I don't really, the below the line, which is tax revenue, investment income, all that stuff is really not, I manage it. But this team, from an operational perspective, really focuses on net loss from operations. The investments, we talk about in pension and investments, so it falls into that committee, but it's there obviously for your viewing. Does anyone have any questions on kind of the operating statement overview?
What was the settlement, the $5.4 million?
It was a settlement through CCP that they fought for, was it 10 years that they were fighting it with ACA, and there was a $13 million settlement, and we were entitled to about $5 million in that settlement. And the money has already been brought over to us in a check as well.
So, is that above the line or below the line?
That was actually above the line because that was revenue that CCP owed us for patients that were in our hospital.
Had ACA underpaid? Was that what the issue was?
Correct.
Yeah, but when were those patients in the hospital?
Years ago. It was 3 years ago.
So, how do we put that into operating? Doesn't that skew our data to say that those dollars you added to our net, decreasing our loss, but in fact they weren't really produced last year. Those units
Correct.
of service were not produced last year.
But the settlement was for this year. So they settled with this year.
I get that. I get that. But they're settling for units of service that were provided previous to this or last fiscal year. It had to be a couple of years ago.
Correct.
And that's $5 million.
5.4, yeah.
So it does skew these.
Right. So
figures
if back then, or 5 or 6 years ago, when they started the settlement process, the CFO or team could have put a reserve on the book saying that, hey, we think we're gonna get this, and taken it into income that year. They did not do that, so as we get these Medicare cost settlements and all these settlements that come in, we've just made the financial decision just to have it in this year. So when we take a hit, we take a hit, when we take a pickup, we take a pickup.
Does this appear under other? Is
No,
that-
this goes, it was operating revenue, so it goes in the operating revenue.
Oh,
But above the line.
Above the line,
So,
right.
so in reality, you take that money out, we are not year-to-date over the budgeted loss. We're under by 2.5 million. Right?
Correct, but that's if I can provide, at the next finance meeting, and for the budget presentation, I will, there's a whole reconciliation of, debits and credits that go into our year-to-date number.
But you understand how important it is when you make a determination as to if people are gonna get bonuses or not based on operating revenue. Well, we've budgeted a loss. We're talking about rewarding people for losing money, but not losing as much as we lost last year, right? In this scenario, this puts in $5 million above the line that I believe probably should be below the line or somewhere else. But, I mean, I'll leave it to the rest of the commissioners to look. I was not aware that someone, I met with CCP yesterday, and John talked about, when we met with him, and John talked about it, I thought he said we got 68% of that settlement.
66% or 67%.
So out of 13 million, 67 would be more than that. What am I getting wrong?
Some of it was accrued in the past, because they thought we were going to get something, so a portion of it was accrued, and then the settlement was above and beyond what we thought we were gonna get.
So going back to what Alan said, when he said they could have chosen, they did choose to do that, but they chose to do that
At a
much
much
less
conservative-
amount, not assuming that they were gonna get as much.
Right, as a much conservative, they took the conservative approach to it.
I think we need to put a placeholder in that, because that's gonna become relevant in some of our future discussions. So,
Sure.
you can continue that.
Okay, so does anyone?
Either way, that'll come out of the audit, so.
Right.
And we're gonna deal with audited financials.
Correct. It would be a footnote in it would more than likely be a footnote in the audit.
and certainly when we consider bonuses, we take this into consideration.
Well, right, as long as you take hits that are not in the current year operation too, so it has to be on both sides, in my opinion. So if there's something that we took a hit on, that was above and beyond our control, then I would assume that we would take that out as well, if we're gonna go with that approach, in my opinion.
No, let's put a placeholder in so we can, and any other issues like that, you need to identify to us so we can take that all into account and see if there's a wash or not.
Anyone have any questions?
So that 5.1 million was in the May revenue number?
In the minute, yeah.
So we would have been at 86 million or something current, the actual?
For net operating revenue.
Right.
Yeah.
Okay, that's fine.
And then there was also we took the opportunity to true up some of our accruals, and so it all netted out to, an unfavorable variance of 1.4. We were right at budget,
Okay.
or right below budget.
Do you expect any settlements that are gonna come due that are gonna be material that you project in the next 6 months or anything? Nothing, okay. No, there's nothing out there that we think that might get resolved that we could be owed money for? Okay, fine.
It could be the other.
The Medicaid stuff.
The Medicaid stuff, that's every year.
Yeah,
It's in,
and how much is the Medicaid stuff, approximately? That could,
I mean, there's a few million out there from prior years on chewing up the rate changes back in 2012.
okay, but it's not a huge amount, it's a couple $1 million for over multiple years.
Yeah.
When and if that does occur, we need to be told when that happens and how much it is, please.
Okay, moving on to page 3. This is kind of our key indicator page. I've been focusing all year on line 3, overtime and agency as a percent of productive hours. If you look, we're at 2.9% at a budget of 2.4. And then on a year-to-date basis, we were at 5.2 and we're down.
What line are you looking at?
Line 3.
And the 2.9 is the first.
Yeah, the 2.9 is the current month of May, on a budget of 2.4. Prior year was 5.2, so we decreased it 43% from prior year. And and then on a year-to-date basis, it was 4.4 on a budget of 3.4. So that was, what we did there was is we gave them a long runway, the team, each month we decreased it. So we had a nice start, but it didn't go as quick as possible. And then when I go over June, you're gonna see for the year, for current month June, we actually got to our goal of 2.5% in a year.
What is that reduction, because it's nearly in half, right, when you look at 5.2 that you can close, but what does that equate to cash?
About $4.3 million in savings for a year.
Thank you.
And what do you attribute the little bump up this month or May for?
Well, May is actually, if you see prior month, it's actually coming down. The budget, what I thought was is I need to put in the target at 2.5% because I needed to make sure that people understood that it was in the budget and be held accountable to it. So if you want for next month, I can show you a trend that each pay period, and we monitor it, you could see it coming down, and then on the last pay period of the month, we hit our goal of 2.5%, which was we're all very proud of. It's been a team effort from every person in this organization.
Yeah, based on the prior year.
Yeah.
Are there any specific facilities that are doing better than others at hitting these goals, or?
Yes, there actually is, and it's very competitive. I
Would you
think
like to share that?
Yeah, I think medical center.
So medical center, for the last pay period, we got down to 1.9%, which we tied Imperial Point for first place. I'd like to note that while I am the interim
They get
CEO.
That's why he's talking, because he's the interim CEO and he's taking credit for that.
I'd like to say that while I am the interim CEO, frankly, all the credit should be given to that team, Heather, because I haven't changed anything since I got there on the overtime piece. The first day I walked in, they have 2 meetings a day. They call everyone up who could potentially be over that number, and they have intervention meetings about it. So they have really put a phenomenal plan in place, and that's better than industry best practice. Also of note, we had the clear visit for ACGME, and one of their comments that they were so impressed with was that prior year, we were at over 7.5% on overtime, and one of their major concerns is burnout. That could really affect quality. So they were super impressed with the fact that the system was able to get down to 2.5% overtime.
What's ACG?
ACGME is the association that credits our residency programs, and so they came in and basically it was a learning experience to survey how we were performing in terms of our responsibilities to our residents, and that was a big focus. So there's one of the 6 pillars is quality for that, and quality and burnout were 2 of their focus areas. So they
And
were
is
really
much of this residence, is that much of this overtime?
No, it's not, but when they come in, they look at the facility holistically, because the residents that are practicing there, it's about the total care for the patient, and so they actually were interviewing nurses, techs, EVS representatives, so they interview pretty much everyone.
So as a private business owner, I despise overtime. And we have a rigid schedule. There's no need really for a business like mine to have people working overtime. You have different factors in a hospital. So I commend you guys for getting it down that much, and the equation of $4.3 million, that's significant. A couple points doesn't sound so great, but $4.3 million is a nice reduction in that overtime, because that really is a part of scheduling. But again, as a hospital, you're not going to be able to get that down to nothing. But the numbers are looking good. I'd like to see the trend line too.
And Commissioner Bear, I also want to say that now there's dollars that we can equate for quality patient care, not the so the nurses, the doctors, everybody's fresh. So that turnover, there's a lot of, that we can put dollars for the actual, for patient care.
And what's refreshing is when we walk around the hospitals, I'll have, because we do calls, me and Gino and Bev and team, we do calls on a bi-weekly basis after payroll, and we hold people accountable to their overtime, and all the directors are on there. And as we're walking through the hallways, their departments know their overtime rate and where they're at, and it's nice to see that they're really buying into it.
Very engaged.
Very engaged, so. Perfect. Okay. So the rest of this are key indicators. Anyone have any questions on them? Do you want me to go into more detail?
Could you just walk through number 8, what's going on there?
Yeah, that's margin operations, so that's just net operating, gain or loss from operations divided by net operating revenue. As you can see, our net operating margins year to date are down, are better, improved by 3.7% over prior year. That's gonna be key when we go to the credit rating agencies and they show that we have an increased or improved margin.
So I look at the year-to-date first budget, and you're right on it, but I see the current month is off. Is there,
Well, the current month is off because we had the pickups in there that drove down, increased the margin operations.
right, so if you take that out,
We would've been right at budget. I would have to do the calculations real quick,
Okay.
but I think we would've been right. We were right on budget, so we would've been right, the margin operations would've been right on budget.
Okay.
Just one thing that I do wanna point out on the year-to-date number, that we took a $24 million Medicaid hit to our bottom line, from Tallahassee. So the fact that we were able to increase our make our margins more favorable with the $24 million hit is a nice accomplishment for the year.
So, you refer to these as key operating indicators. Who in the organization is evaluated based on the performance of these indicators? Anyone? Is anybody held responsible either positively or negatively for these indicators? Or are these just global indicators?
Okay, so how it works is we have monthly MORs. It's really the executive teams of each one of the hospitals that are held accountable to it. So these are kind of my financial indicators that I look at, and I have finance MORs on like the 9th of the month or.
So if these were bad, does Bev then evaluate you on the performance of these indicators?
Yeah.
So these would be included in your performance evaluation?
Oh, 100%.
Okay.
As well as
Anybody else?
the hospitals, right? So
Yeah.
Al and I would discuss it with Alan, and then Alan and Alex would discuss it with the hospitals.
How you proceed to get it done is one thing, whether or not you're evaluating is my question. So if you're these are key performance indicators, right? They're key, they're critical. There's other things that I think you're gonna get to that I also would include, but I wanted to make sure that the people in finance, including the hospital CFOs, understand that these are critical to them.
Yeah, we have our monthly MORs, and if they're over on a supply per adjusted patient day, they have to give a detailed, because there could be a reason, right? Maybe they're using high implant costs and there's revenue to offset it. So obviously, I evaluate them, but I'm fair about it, and I have them provide me explanations on kind of where they're at with their supplies and what they're doing as well.
There are no, Janice, there are no map keys to this, are there, that you know about?
I'm not aware.
Are you aware of any HFMA guidelines on these, where they should be?
These are, I go to like the advisory board and kind of, these are the budget, so I kind of been using our budget, which is probably, we should really look at more.
It'd be interesting to see what hospitals like us do in the way of overtime. They have 2%, are they 5%, are they 6%?
Well, I know 2.5% is industry standard.
Okay. So even having that somewhere to be able to say,
Sure.
industry standard's 2.5, we're at 2.4,
Okay.
how much better are we gonna do than that? Set a real, so Gino in his temporary interim roles got it down to 1.9, right, Gino?
That's right.
Is there expectation that you'd stay there? I imagine not.
So that's a good question. So industry best practice is 2.5%. You don't want to get it much lower than that, and you can't look at overtime alone. So one of the things that we've also been doing is looking at what our ratios are, because if you're getting your overtime down at the expense of ratios, that's a problem. So one notable thing that we're really proud of is that while we've been able to get the overtime down, we've actually improved patient ratios while we did it, which is why it took a little bit longer. But to answer your question, you don't want to get it down too low, and I'll give you an example. Right now, for this pay period, we're up a little bit on overtime, but it's a good thing because we are busting at the seams on our behavioral health patients. So it is not a volume that's going to stay that way, so you don't want to hire up to be able to keep your overtime down. You want to be able to use overtime for the short bursts of volume, which is why 2.5% is about where it should be.
Just when you have numbers like this, I think the board should know that's where it's going. And that's, when you look at that trend arrow, if it doesn't go down, that's not bad, probably where you need to be, and you're maintaining a key metric.
The next page is the statistical overview. This right here is kind of our biggest opportunity moving forward. We've done a really good job as an organization to cut costs and to drive a bottom line. But if we're going to ever be a sustainable organization that really has significant decreases to our millage rate and our tax revenue, we're going to have to really focus on volume and growing our business. And you know, we've had some volume deterioration in admissions. You see a little bit of, I'm looking at on page 4, line 3, if you look, we were 9% down from budget and 7% down from prior year. A lot of that is, if you look at short stay cases, which are observations, when you come in, you can either go into an admission or you can go into an observation. So you can clearly see that there's a flip from admissions to short stay cases, but it's not, the flip isn't significant enough to show that we've had some volume deterioration in our admissions. So we've been working diligently with the facilities to build strategic plans to try to capture the volume into our facility and try to figure out what's going on and where the patients are going. Is it just the market is decreasing as a whole? Are we losing market share? Why are we losing market share? Is it a quality of care issue? And what can we do to fix that in the future?
Explain for me the difference between short stay cases and short stay days.
So short stay days is when you come in on an observation, it's an hourly calculation. So every hour you're there is that's how we charge. So if you're there 24 hours, that's 1 day. So basically if you take the amount of days divided by the cases, that'll tell you the average length of stay of an observation patient, and that's a measure that we're constantly looking at. Best practice, industry standard is 23 hours. That's a Medicare guideline, the 23-hour rule, and basically we're running about 1.2, 1.3 as a system.
So the cases are the patients.
The
and
patient is
some
an
of the
encounter,
patients-
yeah. So if like, you know, I go into the hospital and I have a syncope and I'm after this meeting and I have to go to the hospital or something.
I got that.
But I'm not like, there's not enough where I need to be admitted, but they still are uncomfortable sending me back to my house. They'll keep me in observation for 23 hours.
And is that in ER?
No, you actually go to the floor.
Oh.
And it's, you get, you know, you could go to the ER, but more than likely they'll move you to a floor, they'll put you in a bed, and they'll monitor you. They may do some additional tests to see if, you know, things are improving, and then they'll send you home. If you get into the observation and things start to get worse and your vital signs get worse, then they'll flip that from an observation into an inpatient admission.
I see, thank you.
And the max on observation, what's really the guideline? Is it-
Best practice is 23 hours.
But you can go.
You can go up to 48 hours is really the kind of the target or the bogey that we're looking at to try to see what's going on with the patient. If you can't determine if a patient needs to be flipped from inpatient, from observation into inpatient after 48 hours, then we escalate that to our chief medical officers and the clinical care team to figure out what's going on.
So you're at about 26.5 hours. Is that what you said? Is it
Let me just do the math and I'll. For the month, we were 1.3. So 23, yeah, 32 hours. Okay, you know, if you keep going down, like, there's a lot of red there. Once again, we have plans in place. We're working on trying to figure out what's going on. If we've lost market share, we need to figure out a way to figure out why we lost market share. If it's a quality care issue, we'll fix the quality care issue. That's sort of our next year's kind of goals.
Just one thing, what do you attribute the uncompensated care numbers dropping so dramatically?
So the uncompensated care admissions decreased because of the way that we started to designate people in the system. So we put them in a Medicaid, and they were before in uncompensated, and now they're going to compensated. So there was a change that was made prior to me getting here.
But are you actually getting paid for them? Or are you putting them in Medicaid when they really?
We're putting them in Medicaid pending, and then they're
moving after that.
Yeah, and then we're aging out the AR.
Does that get trued up at some point?
Each month it gets trued up. From the statistics, the compensation gets trued up if they go from a Medicaid pending to a Medicaid or the insurance, that gets trued up, and then as we reserve it, we put on a Medicaid reserve, and then as it goes, it keeps reserving out to like basically zero if it, over time, which is standard reserve accounting.
So you're presuming some coverage and they're going into compensated while you're.
Right, because Medicaid is compensation, so that's why. Before they were going into uncompensated. I'm gonna move on. Does anyone have any other questions?
Just line 12, community healthcare visits. So that was down 18%. What, is there,
So we lost several providers. Our contracting process, a lot of these individuals were not on contracts that were satisfactory for A, the business operations, and B, compliance.
right?
So we had to redo the contracts. We lost several providers. We have been able to rehire a portion of them, but we're not fully up to where we need to be as of yet. That's the main reason why we're down.
So you think that'll trend back up as we staff up with new contracted?
I do. I think the combination of adding the adequate providers as well as adjusting our scheduling. You know, we have an RFP out right now for centralized scheduling,
Right.
which will also, the operational changes they're making to help with the no-show rate and transportation and things of that nature, I think will get this number back up, yes.
Do you see this trend every year in the summer months where people go into other areas, or is this a little unusual?
Not so much in this area because our community health visits are more the,
I mean, overall.
It should be budgeted, so when you're looking at the presentation, we should be when we budget and we'll
You
go
take
into,
that into
we'll take into
consideration.
consideration, so we just don't say there's 1,000 visits divided by 12 and each month. We look at a 3-year historical trend. Based off the 3-year historical trend, we come up with a mix of how we want to spread out those 1,000 visits for each year. So it kind of gives you guys, from an optics perspective, kind of a flex budget, we'll use that word, to show where the volume should be based off of historical.
Because
volume.
most everything is down from budget on this month.
The volume is gonna be our biggest single thing that we need to improve next year, in my opinion.
I just have one more line. On line 11, year-to-date on outpatient medical center visits. So it looks like it trended up for the month, but over the year, we're down 14%.
Are you looking at line 11?
Yeah.
That's from prior year.
No, I'm looking at the year-to-date though.
The year-to-date to budget is over positive.
Right, I'm saying, I'm looking at the variance for year-to-date,
Yeah.
down 17%. I mean, I know we're working on, you're up this month, so is there anything going on in that outpatient center that?
So what's in those outpatient visits is a combination of, we have indigent clinic, which we have follow-up visits for. We also have, that's gonna be your radiology visits as well as your outpatient physical therapy. That's the bulk of everything.
Right.
We lost at medical center alone about 17 physicians that had a lot of patient contact, and part of the same reasons I just discussed with the
Okay, so
CHS.
it's
So
along those lines, okay.
that's exactly why we're down.
So as you staff back up, those numbers should be coming back. I mean, it's fine
Yes.
for the month, I'm just looking at year-to-date versus last year.
Yeah.
So that's not you don't think it's a long-term trend, that's just a short-term situation, is it?
I think it's gonna take a while to get back to where we were,
Okay.
but I think we're headed in that direction for the new fiscal year. We
The
worked a lot.
The pattern of the physician losses, is that because the contracts were not in line with our obligation?
That's correct.
Contract?
Okay. that's
So,
fine.
good, they're gone. If they wouldn't agree to a contract that complies with our obligations, good, they're gone.
Yes, our focus has been on compliance and on quality and operating margin. So volume has taken a backseat priority to that, and I think as we restructure things the right way, the volume will come.
If you build it, they will come.
So Gina, do you see in those,
So clever and original.
in those lines 11 through 15, do you see any opportunities for some expansion if we had resources to apply to that, or is it just?
So, yeah, I mean, if you look at most of these, it's gonna be the same reason for for everything, except for, and I will say, except for our urgent care centers. The volume there has come down a bit, but our operating margins, our total losses in those areas have actually been cut by about 30%. In the budget for next year, which we'll be bringing, we're gonna cut about another $1.5 million of losses out of those areas by restructuring. Right now, we have a very high acuity model, but our demand is very low acuity. So we're converting to meet that demand, and some of our strategic initiatives, which hopefully we can go over in our strategic shade session, will involve some of what you're saying, and I do believe we can capture some additional business.
Because I would think that there's opportunities around the community in our
Especially in
area
some
to
of the
grow that
development.
part of the business, okay.
Absolutely.
Good, okay.
But you have tremendous competition there, don't you, with the urgent care centers?
I love competition.
But it's.
There's been a lot of competition on the urgent care front, but I believe when we review our strategic plan on this particular note, you'll see that that's not going to be an issue for us.
Because where I live, there are 5 around me,
Yeah.
but not us.
You know, just one other item on that, and Alan as well. The last couple of items we were talking about in terms of outpatient medical center visits, community care visits, part of that is due to loss of physicians. You referenced, contracts and compliance. My understanding is that there are physician issues concerning the contracting process. Is that a factor here in terms of getting the contracts done and executed?
Not largely. There may be 1 or 2 in there, but the timeline really was not their issue. The issue was that we migrated them to contracts that were compliant and had the necessary language in there. Some of them did not like that. And the secondary piece of it was that our compensation structure in the new contracts match a base plus productivity at a fair market value level. In the past, I'm not confident that that was done appropriately. So as such, some of these individuals either ended up getting paid less, or where there were leases involved and we had to bring leases back into the fair market value range, their leases went up significantly, some to the tune of 20%, and so they relocated out of the area. Unfortunately, I think this is cyclical. I think we're market competitive even with our new rates, and so eventually some of these individuals will come back, or we'll attract other ones, but this is the initial ripping the Band-Aid off. This is the result of it.
Right, so that's, I guess, where I was getting at. So part of this is cleaning up historical issues that needed to be cleaned up both for compliance and contracting and financial purposes.
Yes.
And we've been offsetting kind of the losses of the volume with expense management to help through this transition period.
Okay. Thank you.
So the next slides are just kind of informational. As I've been saying each month, the operating results by entity we can look at on an actual versus budget current month. But prior year, PPUB dollars were always sitting on corporate books and not on the facility books. So when you're looking at a comparison year over year, it's not going to compare. So I'm more than happy to go over each one of the facilities' kind of operating numbers. It's more for informational purposes.
As I looked at this, I mean, if you look at it, Broward Health Medical Center is losing $28 million so far. Broward Health, $33 million. None of our projects are making money. Every single one of them is losing. I'd like to know Broward Health other, but what I really think would be helpful is possibly at the next finance committee to have the CFO and CEO of each of these facilities come in and tell us what their plans are in conjunction with VED, as to what the plan is to turn that around. We need to get these things to zero. I know that's not gonna happen overnight. I know it's a plan. I went and met with them. I like the vision. I like what I heard. I like the teams. I think it would benefit everybody to see them come in and talk about what they wanna do and what they're trying to do in order to turn that around. I think they're key, obviously, to your success, to our success, is doing these. These numbers are staggering. And the fact that none of them none of them, and hopefully there's some things in this Broward Health Other that are profitable. But 47 million, you take Broward, you take all other, and you take North, and it's more than half of our losses in those two buckets. At some point in the private sector, you start divesting the losers, you start getting rid of them.
Yeah, I know-
Obviously, we won't do that, the community owns this, but we have to figure out how to get these things right side up.
The only thing that I'm going to, talk about in these numbers here is that in the private sector, you would be looking at EBITDA, which carves out depreciation. These numbers have depreciation in there, so when you look at some of them, when you add back the depreciation, most of the, like North looks like they're and they have a lot of improvement, but North from a pure revenue minus expenses is.
So what do we have, about $500 million in physical assets that would be in the depreciation?
We have about $58 to $60 million of depreciation.
So that would be half.
Yeah.
That doesn't
So we're-
get us all the way there.
Right, so like, so what my goal is basically to get us to get that delta smaller, that's what we're working on. And we can look at reports, this has just been how we've always looked at it for years. I've come from the private sector, I've always looked at EBITDA, or EBITDA, as kind of an operating measure. Depreciation is a non-cash expense, so it is what it is.
But doesn't this also reflect the fact that we're a safety net operation and we're not gonna be paid by a lot of people?
I can't accept that as an excuse. I think that we can run profitable. I think that like in 1 year, we've identified $31 million of low hanging fruit, and we haven't even gotten started with revenue cycle enhancements, with managed care enhancements, with building best practices of surgical centers. We haven't done anything. We found $31 million. There's a lot of money in there, in my opinion. We just need to continue to be diligent in our expense management.
But at this point, it does reflect that we're not being paid. I agree we need to correct it, but these figures reflect that we don't get paid for a number of our patients.
No, we get paid for our patients. Our rev cycle, every patient that comes in here that has funding, we go after every single last dollar of the funding. So, obviously it's our mission to take care of the
And they all have funding?
Some of them do, some of them don't.
I think your point though is that we have a large portion of charity, which is uncompensated, and in addition to that, our payer mix is not optimal, right? We have a lot of Medicaid, and there's not much of a margin on the Medicaid business. So I
And I
think
agree, we
you're
have
right.
it corrected, but the
Yeah.
figures as they are reflect that.
That's right.
And it's going to take a 3 to 5 turnaround. We're heading in the right direction. He said that we've saved 31 million already on our first year. But to your point, Commissioner Berry, we know we've got room to improve. The CEOs, the CFOs, I love having them come. You will see that they are just as engaged as we are. It's gonna happen, but unfortunately, change doesn't happen, as you know, overnight. It's a good 3 to 5 year plan to get us where we should be.
And in that plan, there needs to, not just the cuts, expense,
Not the
but
cuts.
I wanna see the revenue side, because there's revenue there.
You can't cut yourself to the bottom. You can't cut yourself to the bottom line.
There is revenue out there, and we can get, you're gonna be demonstrating later today some of our new systems that should draw some other folks to us. We used to have a really stellar ortho program. We need to build that back up. Ortho is a high cost, high reimbursement type system. So there's a lot of things that we can do, and if you look at we get lit, right?
Yeah.
We get charity care, we get tax dollars. So to say uncompensated isn't entirely accurate, because we get compensated somehow. We get compensated by the public. If our revenues were higher than our expenses, we could pay for our own. The South Broward district is pretty effective, but I understand their market's a little different, and there's a bunch of different issues there. My business is going into hospitals and helping them get revenue out of nowhere. If you have an emergency room, you're getting uncompensated care patients to your emergency room. Anywhere in the country, if you have an emergency room, you have to take them. So whether this is the number, if we get to a point where we think $50 million in loss is the best we're ever gonna do, that's fine. But we need to know what that number is. It's not $140 million. We are better than this, much better than this, and we can do better than this.
We understand. Agreed.
One other thing, on the trend question and where we are as a system, I think it'd be helpful to see some further overviews relative to prior years. We do look back, you know, this is obviously the results are compared to the prior year. Some of these are, you know, the cash collected goes back perhaps more than 1 year. But, you know, perhaps if we look at the last 3 to 5 year trend line and where we are on our current trend line, I think that would be helpful for the board to see.
No problem.
Because then we know, you know, historically we're heading in the right direction. When we look at the quality care, for example, a lot of those numbers go back several years. Unfortunately, some of those aren't reported on a current basis. Obviously, finances are. But I'd like to see, and I think the board would benefit from seeing, you know, where we were historically. And let's recognize the fact that the system has had some issues.
Okay.
Over the last several years, right? And we're cleaning up those issues, we're fixing things. The numbers should be getting better, they are getting better, but let's see where we were and where we're going, and then talk about how to adjust further to get where we need to be.
Understood. Now 6 is my favorite slide personally. This is kind of our balance sheet strength. This is what Moody's and rates us on. Probably our strongest liquidity ratio is cash on hand. If you look at we're at 233 days cash on hand. That doesn't include the additional $90 million we took for the capital project. So that's cash that we have increased this year by cash management, capital management. And so our cash on hand is 233, which is above A rated.
Does that include the collateral capital that we got back?
Yeah, there was $25 million of collateral cash.
So that's in that 233,
Yeah,
right?
that's about 5 days.
Right, okay, that's good.
Accounts receivable, I wanna hold we have a plan for that, it's going up, and we have a presentation on what we're gonna do to go down, so if you're okay with it, I'm gonna go, are you okay with that?
Yes.
Sure. Cash to direct debit is another one of our great, ratios, 208 is phenomenal. The reason why it's gone down is because we took additional debt on from the bond, so that's why it's gone down from prior year. Debt to capitalization, 26 is, you know, higher is better, we're almost there. Debt service coverage is, we still have a little work to do, but obviously we have some debt on the books. And then our capital spending ratio, what we're doing with this is we are bringing it to 100, our capital ratio, the budget that we're gonna submit is gonna be right around 120% next year. And that'll be in the budget next year. And then our excess margin, this includes investments, is 3.2 for May. And that includes investments and CCP and all the other stuff that goes into our numbers.
Including the tax.
What happened to our debt service expense as a result of the refinancing? So how is that impacted?
So that's a great question. So we had the swaps on the books, and so what we have to do is that the years remaining on those debts that we refinance and all the swaps, we have to amortize those out throughout the year. So that's what happens. So it's sitting on our balance sheet, and then each month we're amortizing it down until it goes away over.
So what's our total debt service on an annual basis now with the refinancing, everything being?
About $12.5 million.
And prior to it, it was?
It was like 16, 17.
That's right, so, yeah, so it's $4 million a year. And so you're amortizing how much of that?
We're amortizing the swap. You know how like we lost on the swap, the mark to market on the swap? We're amortizing that over the remaining.
Yeah,
I actually have the exact, I think it's like $25 million.
25 million over what, 5
Like
years?
I think the average is 8 to 10, because we had 4 or 5 of those bonds, so we had to take, each one of those bonds has to match to what was remaining on the bonds, and then we amortize those out, so.
Right.
So
you're
it's an
taking
average
that-
of about 8 years.
So you're taking that 25 million, you're averaging it out, and it's going against us, okay?
You know what I think is a good idea, since we have some new members on the board, is we have PFM, who's our bond consultant. If you're okay with the Commissioner Bear, I think he could come back next month and give a presentation of where our bonds are. It's a good look back to see, you know, this is what you guys got, this is what the market is doing right now, and kind of give us an update on that. That's part of his agreement that we have with him, so.
Yeah, and I think from a timing standpoint, getting that refinancing done at year end made a difference, because there's probably been a 50 basis point move.
Yeah, we got in just in time.
Yeah, since then, which would have really affected our debt service
Yeah.
coverage.
And then the next is cash collection. I don't love this slide. We're gonna redo it, but it's just kind of an illustration of how much cash we're collecting. And then slide 8 is.
Hold on.
Oh, go ahead.
Hold on. on this slide, if you look closely, we're down revenue for this calendar year, every month except for April. Is that correct?
Yeah, remember that there was a 24 Medicaid, we took a $24 million Medicaid hit, but yes, we're down.
Down about, on average, $2 million a month.
Correct.
Our revenue, though, our gross revenue is up. Our net revenue is down, is that correct?
Our gross, yes.
Those are bad directions, right? We need to bring those kind of back in line, and I'm sure when Janice does her presentation, we'll see how she's gonna get more of that money in the.
Yeah, I'm excited for this presentation because it'll show kind of the journey that we're about to take on, but yes, you're right. Cash flow statement, it's just a simple cash flow statement. You know, as you see, this one right here is comparing year-to-date May last year to year-to-date May this year. If you look, you know, like, look at the capital expense, we spent 56 million last year, we spent 70. The change in the accounts receivable, this is just ins and out of the cash flow, but it just shows that, you know, this is why our cash on hand is going up. And then the next one is year-to-date June, I'm on slide 9 now, is year-to-date June versus where we're at in May. So this is kind of saying this is where we ended the year, this is where we're at right now. So one was a comparison, May over May, and now this is at July 1st to May, and see our cash, what our cash is coming up to.
How much of that cash was the cash that came in from the bond refinance?
Well, the bond, there was 90, but we only have 25 left, so we've spent a significant amount of it.
But we're not spending cash. We're not
liquidating
We're not
our
cash
cash.
funding the construction anymore. We did it
With the bond.
when we rolled it into the bond, right?
Even with that though, even with the money coming out of the restricted that was in collateral, we still have managed cash much better from an operational perspective. A lot of the savings that we have, you know, our cash on hand is better because we're not spending as much in expenses.
But our capital expenditures is declining now because the big construction projects are nearing their end.
You got it.
So a year from now, where do you think our capital expenditures will be
I'm
for
trying to
2019?
I'm trying to match our capital spend with our depreciation. That's kind of sort of my goal on a go-forward basis. What we had done in the past with capital management was rollover projects. So I gave, let's say we gave Broward Medical Center $5 million of capital. They were able to roll that over year. And it was becoming an accounting nightmare for people to try to manage these projects. So when we give capital to people, we want them to use the capital for patient care and to improve their facility. So we've gone to a use it or lose it type of philosophy. So you get $5 million and you have to have it received in the hospital by 6:30, or you lose that capital and you have to roll that, subtract from the next year's capital.
But doesn't that, so how are you managing, if you use it or lose it?
Just on the base. So that's like capital that the CEO, so we can give autonomy to the CEOs of the facilities that are running it. So if they want to do a lobby, or they want to, you know, reduce their rental equipment, you know, that's their choice. We want to give our CEOs the feel empowered to manage their facilities. And then we have different buckets of money. So we have like a BSERP, which is basically, or ESERP, which is equipment. As a system, we're going to buy monitors as a system, and that money is subtracted, and we're going to say it's $12 million, and we're going to make sure that we have standard monitors throughout the entire system and invest as a corporate department, as a corporate system based off of the needs that our departments tell us.
Yeah, so who's looking at the feasibility or the requirements of a lose it or lose it project? Use it or lose it project, so that a facility doesn't say, well, we have $5 million, if we don't spend it this year, we're gonna have $4.5 million next year. So how are we measuring what they're spending that?
So we did we got with all the teams, and they submitted in priority level their capital requirements over the next 5 years. So we have a 5-year plan. What's required for them to spend the money? So as an example, we're going to be bringing, in fact, one of the COOs just sent me a message and said, hey, I'd like to bring we'd like to move forward with the cath lab for the facility, what do I need besides the board exhibit? So I said, well, we need the performa. So in order to get approval to spend their money, even though it's at their discretion, they still need to get approval, and part of that requires that it follows through PSC so we know they procured it correctly. Part of it is for the design and construction piece, because this was an issue we faced in the past. If they say that it's gonna be $2 million for the cath lab, I'm having David Clark's team review it, because what we're finding is that they're significantly underestimating the costs. So we wanna make sure the cost is right, we wanna make sure there's a performer there, and it's not just spending it just to spend it. So there is a process in place to get approval to do it, even though it's theirs.
Right, so they submit you a wish list, you're checking that wish list off on an ongoing basis.
Yeah.
And replacing items as you go forward. If they check off 2 items over the next 3 years, they're gonna replace those with the next set of wish lists.
Exactly.
And so okay, that's fine.
And we give them the autonomy to, let's say they wanted 5 million, we give them and they only get $2 million of the base capital, we give them the kind of the autonomy to pick and choose which ones they want to move forward with based off of the needs of their facility.
Off their pre-approved
For
wish
the,
list.
you got it.
Okay, and the last thing is, what is our annual depreciation on the 500 million plus in assets?
It's about $58 million is what we're projecting.
58, so that's right in line with where your capital expenditures are this year, so you think that'll continue to trend that way?
You got it.
Okay.
Well, the only thing is our depreciation expense is gonna go up because we just had $300 million go live in a lot of our projects. So,
Right.
like when you look, you're gonna see a significant uptick in our depreciation costs because of that.
Well, but it's gonna match whatever our straight line depreciation over time of our
You got it.
physical assets will match our capital
You
expenditures.
got it. That's kind of my goal. That's what sort of our target is, and that will help us keep our financial indicators from the liquidities perspective in line.
Okay, I mean, there's obviously gonna be the one-off unexpected event that we can't control, we gotta replace a generator, costs us $1 million.
But we
Those
actually,
are things gonna happen.
but we account for that too. So
Right.
we take a holdback, so we don't give it all to them, because if you give it all to them, they're gonna spend it. So Gino has I call it the Gino bucket of, emergencies, and then Gino kind of says, okay, this is emergency, we can release it, as he sees fit. So we account for that, and we put a contingency for ourselves, because I can't keep coming back to the board and saying it's a $58-60 million capital, and we spent 75. That's not, unless there's a reason, right?
Right.
Unless there's something that, unforeseen, then obviously we come back to the board and let you guys know about it.
Just so you know, the majority of those that come out of my bucket, they don't really have that ROI performa on them. So as an example,
Emergency
yeah,
situations.
the BDA, right? We had to do the bi-directional amplification system.
Right.
We had to do it, right? So it's things like that.
Okay, but I mean, those are things that we can't control and we need to do
Yeah.
anyway, so that's
Right.
what I'm asking, okay.
Okay, so that's my May. So for June, is there any questions on May or, okay. So for June, I have this for you guys for informational only. I'm not gonna go into great detail. We have not closed the month, of June yet, where I'm still getting entries, that I'm uncomfortable with. So I'm not prepared, at this point to go over in great detail. There's a lot of, debits and credits in these numbers because it's year end and we're doing final approval adjustments. So, if you want, I can go over it, or would you just prefer for me to give you guys final numbers as of June, next month?
I think we should just see final numbers next month, but
Okay.
to be clear, explain the closing schedule for everybody.
Yeah, so we when I got here, they used to close like 12 days, and we made it to more of a profit field, so we closed the books in 5 days, 11 months out of the year. And that's why I'm able to come each month and have final numbers for you. This month, because it's year end, and there's significant things tied to our year end numbers, I made a commitment to the board that if I didn't feel comfortable with the numbers, I wouldn't bring them. So what I did is I left the month open, and I'm gonna continue to leave the month open for another 30 to 40 days until I feel comfortable, or less, until I feel comfortable that the numbers are the numbers. My goal is to match the June financials to be the audited financials. And until I feel comfortable with that, I'm not gonna bring them to you guys. But I wanna kind of give you that, we had a really good month. There were some significant pickups, that were in there, but I don't have the detailed explanations to really opine on it yet, so I'm not ready to bring it.
When you say closing schedule 5 days, you mean 5 days after the end of the
Yeah,
month?
so
When you
the
close?
first business day of the month, they have 5 days to close the books, and then we do our close call on the 6th day of the month with them. And we do that 11 months out of the year. So this as long as I'm here, June will always be a little, different from the rest of the months.
Just briefly, one clarification. When you, one of these charts shows monthly patient payments. When you say patient, you mean self-pay and insurance. That's everything, right?
Let me just make
It's
sure.
in tab 3 near the back, right before AR days. So you show January, you show calendar 15.
That's insurance too.
That's, yeah,
That's-
it's not just
that's-
patient, it's everything.
The one thing that I do want to point out, and this is why I wanted to bring June here, is if you look at slide 3, line 3,
Slide 3 of the June one?
yeah, if you go to the June. If you look at overtime and agency as a percent of productive hours, you guys see the 2.5 that we promised you. That's really why I wanted to bring these to the room. So with that, that's gonna kind of be my June financials. I would suggest that we make a motion to approve the May's interim financials, to go on the consent agenda for the board meeting tonight. Which we've done in every other meeting, unless you wanna go over this in detail again at the meeting.
I just have one question for you. On page 6, the accounts receivable days, what's a day of cash for us?
A day of cash is about $4 or $5 million bucks.
So year over year, it's almost a 10-day differential.
Yes.
So that's $50 million in cash, and we have the additional cash.
And we have a whole presentation.
Right, I'm just saying, this has
Yeah.
been growing, and I think I've mentioned this several times over the last year or two, but that's a concern of mine, is why is our receivables continuing to grow?
Right.
when, you know,
It's going to be, I agree with you, we have a whole plan in place to get the ARDs down to where we need to be.
Okay.
One of the charts in here had, cash per day. Do you remember where that is? It shows, there's something you put in here that shows per facility. Okay, in tab 2, probably the last page in tab 2, doesn't this show cash per day per facility, net revenue per day? So am I reading that right? Is the net revenue per day $2.7 million consolidated? Am I reading something wrong?
Are you looking at?
I'm looking at, in this booklet, tab 2, the last page of tab 2.
Oh, okay.
So by facility, if I'm reading this right,
Oh, you're right, yeah, so,
yeah,
about two, you're right. I'm
Broward General's
sorry.
$1.3 million a day, North Broward's 576 a day, is that right?
Yeah.
Okay. So then at the end, when it consolidates them, to your question, Commissioner, it's $2.7 million a day, and there's your AR days, so that gives you the idea of where we are.
Yeah, I'm sorry, I misspoke, it was 2.8, I'm sorry about that.
You talking about on the last page there?
Yeah.
So net revenue per day, and then where do you see the cash expenditure per day?
Yeah, so we're, in May was 2.7, which May was
Second plus.
secondly less than.
Net revenue per day.
No, I'm talking about what net revenue is what we take in.
Yeah, so what's gross?
What does it cost us to run a day, expense-wise? If we had no revenue,
About $3 million bucks.
3 million.
Yeah.
Okay, so if it's growing 10 days, it's $30 million of additional cash.
Yes.
We're needing to consider, okay, all right, that's where I'm going at, okay.
This is an interesting slide for those who, anybody that, this kind of stuff. It just shows you the amount of money that's at risk with every day. You lose a couple of days for some event, you lose a lot of money. This isn't some small amount, it's a big amount.
Yeah.
All of it.
So let me just clarify, because I think my dollars include the tax revenue that we get, so altogether, revenue-wise, I'm collecting for, patient revenue is 2.7.
I personally never want to calculate tax revenue.
Okay.
That is the last dollar in. I want to know what we do on our own, and that's our safety net for the safety net.
Agreed.
Is that we go to the taxpayers. So I want to know, in anything I ask, what we're doing operationally, how are we performing, and then wherever the shortfall is, then we go to the taxpayers. So I like this because this is clean. This tells you how we're operating. and where we need to go to get to black.
So
Okay.
2.8 is without tax dollar.
That's 2.71, yeah, right?
Yeah.
That's what we collect on a daily basis at all the medical centers, people paying and.
That is collect,
Yeah.
that's not gross.
And what's the
That's
difference
collect.
between all medical centers and consolidated?
All medical centers, so consolidated is all of them, and then all other medical centers would be like the UCC and the clinics and all that, patient services and all that.
Because you had all other, right? Okay. Any other questions?
There was just one other item, and I think this goes back to Commissioner Gregoire's question. On page 10 of the financials, and looking at May, for example, community benefit summary, you know, I think that provides a pretty good snapshot of where we are in terms of benefits to the community versus government funding sources and the excess that we have to make up through our operations. So, I mean, roughly, for 2018 budget, we're providing $1/3 of $1 billion of community benefits, recovering from government funding sources about 210 million of that, resulting in a shortfall of $120 million that we're making up. Is that fair to say? So I think,
That's fair.
you know, when we talk about.
That was my
Right.
question, yeah. So thank you, that clarified my very muddy question.
One last thing, I just want to make sure I got this right. This chart that shows the monthly collections.
What page are you on?
It's 2 pages before, in tab 2, it's 2 pages before the one we just spoke about with the average revenue. Calendar year 2017, when you go down to the second line from the bottom where it says 79,215,000, I'm assuming you took the average of the first 5 months that are reported. Right?
So this is just a calendar.
I get it. So the first 5 months in 2017, 1, 2, 3, 4, 5. Then that equates to the monthly average at 79 million, because that number's not right. If that in fact is, it should be 82,799. So look at just the second column to the end. You see the revenue, same month last year, 82 million in January, 80 million this January, 75, 73. You see that? So you do an average of calendar year 2018. You take 1, 2, 3, 4, 5, and you're showing an average monthly revenue, $80 million, 660, right?
606.
606.
Yeah.
So then, if what you're trying to show there is the comparison for this year. So you would take in the second to the last column, 1, 2, 3, 4, 5, 6, and if you add all those up and average it out, it should be 82,799, but it's showing 79,215. What am I getting wrong there?
Let me do the math.
Okay.
I think it's a rolling 12, so they maybe
But
take
you-
1, 2, 3, 4, 5, and then the bottom, December, November, October, September, like, of the calendar year, because it's trying to compare, it's probably a rolling 12, but I don't wanna.
If it is a rolling 12, I'd like you to change it to be same store sales essentially.
Okay.
So if that average should be comparative, because what it shows, if you just look at this and you don't really, it shows that we're doing better by month this year than we did last year.
Okay.
When really, I'm only seeing the first 6 months, so I only wanna look at the first 6 months and compare it to 2017.
And if it is a rolling 12, what's the difference between monthly average and last 12-month average?
Well, the 12-month average, the rolling 12 would give you kind of more indication of where you collected in the last 12 months compared to the current month. That's why you would use a rolling 12.
The
Yeah, you
monthly
use-
would just
you
use
use-
12 months, right, of the year. 17, take 12 months divided. The
Yeah.
rolling would be June to July.
Like the last 12 months,
July,
like how you
June.
collected, so it
Ah.
kind of shows you like how you're collecting.
So it's a
Like,
trend.
Yeah.
The rolling 12 is gonna give you the trend. The monthly is just gonna give you an annual average.
You got it. Looking for my calculator.
But you said, so you show the last 12-month average underneath it, which would give you the rolling 12. The one above that, the monthly average should be same to same,
That's what I,
6 to 6. So
that's why I don't
the
understand.
bottom line tells you what you're looking for, which would be the 950 million divided by 12, I assume, giving you 78 million, right?
Because the last 12 months are the calendar year of January to December.
No, the last 12 months would be 12 months from June. So it would be May of last year to June of this year.
Okay, so you're using fiscal year,
I'm not using fiscal, I'm using the last 12 months of the rolling 12, of the average. So what we have collected for the last 12 months, and then compare it against what you collected for the monthly average. But let me table this and, cause I don't have a calculator in front of me, I wanna make sure that that's what the calculation
This is
actually
why
is.
I'm not a financial advisor.
Okay, so we need a motion, are there any other questions? We need a motion to approve the interim financial statements for May.
I so moved. I second.
Second. All in favor?
Aye.
Any opposed? Great. We have plenty of discussion. Do I need to ask for more time?
Yeah, I would suggest moving anything that's not essential quickly.
Well, math is essentials.
Okay.
And procurement is sort of essential, so
Okay.
I think, how much time do we have for the 10 o'clock meeting?
2 hours.
Okay, so if I can, it's already 20. How long does your presentation take, Janice?
Hopefully less than 5 minutes.
You think, that's not gonna happen, but nice try.
I know.
And who else do we have? George, right? How long is yours?
Hopefully less than 5.
Keep open. All right, if I could at least get until 10:30, is that all right?
Yes.
Thank you.
Go ahead, Jen.
Janice?
Morning commissioners, morning your leadership, morning everybody. I assume this is where it's at.
So just so we're clear, we have a board workshop scheduled for 10 a.m. We're not gonna start that at 10:30 a.m.
So embedded in the mission of, in Broward Health's mission and vision is the need to continue to deliver, high quality healthcare to those we serve. We in the revenue cycle do not deliver care, but we take care of those who do. So we are pursuing excellence in the revenue cycle, and as a result, we're beginning a journey to the HFMA NACO board. What is that all about? Healthcare Financial Management Association, HFMA, is the nation's premier membership organization for healthcare finance leaders. They work with a broad cross-section of stakeholders and identify gaps throughout the healthcare delivery system and bridges them through the establishment of sharing knowledge and best practices. The healthcare organization achieve optimal results by creating and providing education, analysis, and practical tools and solutions. HFMA recognizes organizations whose innovative and effective strategies have enabled them to achieve excellence in the revenue cycle. So to be considered for that, you have to apply. They have a Patient Financial Communications Adopter Program, as well as the MAP Award. The MAP Award utilizes industry standard metrics or key performance indicators, KPI, to track the organization's revenue cycle performance using objective and consistent calculations. The M and MAP Award measure the revenue cycle performance. The A, apply evidence-based strategies for improvement, and the P is perform to the highest standards to improve the financial results and patient satisfaction. The PFC adopted as the Patient Financial Communications, it outlines best practices for programs. It looks at helping us to help a patient understand the cost of services they receive, the insurance coverage, and their individual responsibility. In addition, it addresses how we communicate with the patient during the emergency services, outside of the emergency room, and in advance of services. Some of those key performance indicators are net days in accounts receivable, and as I heard, that was talked about during the previous conversations. In addition, it looks at your age accounts receivable that's 90 days and greater. The discharge, not final bill patients. The final bill accounts that are not yet sent to the payer. Discharge accounts not yet sent to the payer. Cash collections. Point of service collections. The bad debt write-off percentage. Cost to collect. And charity care write-off, to name a few. Why now? Why do we want to do this now? Over the last few years, Broward Health has increased focus on the key performance indicators in order to increase cash flow and ultimately increase the financial viability of the organization. Some of the actions that were taken, the organization invested in an individual who carries the Sigma Black Belt. That individual also provided training into several leaders within the organization who then achieved the Six Sigma Yellow Belt. Several projects were undertaken that consisted of items within the revenue cycle flow. We developed revenue cycle scorecards that already contain some of those key performance indicators I mentioned. We established revenue cycle roundtable meetings. We've implemented a new contract management system and a denial reporting system to be able to look at things at a granular detail within the revenue cycle. We see the HFMA MAP Award as the next level as we continue to pursue excellence within the revenue cycle.
Who is we? When you say we, who's
We,
involved in?
the revenue cycle starts at the point of patient intake all the way through until we bill for the account and get paid. So all the employees within Broward Health that makes up, that does those roles are part of the revenue cycle.
And have we applied for this yet?
We're going to, we're beginning the journey, so this is the announcement to the board
Sounds like
that
an
we're
amazing
starting.
program.
I'm sorry.
Sounds like an amazing program.
Yeah.
It will solve a lot of the problems that we see with the collection.
By measuring ourselves, applying for this and taking advantage of some of the best practices that this organization offers would help take us to the next level.
For full disclosure, my company is a member of HFMA because we implement these keys with all of our hospital clients. This is a long journey. It's not going to be something easy for Janice to accomplish, and there are a lot of measures that are put out there. There's some things that I want to see in this. I'm going to be expecting invitations to some of these meetings. I've done this for 20 years. This is an area where I can help the hospital tremendously by pointing out what some of those indicators are. It is critical. You go into hospitals, a lot of them neglect the revenue cycle. This one does not. Alan has made it clear, and I've known Janice for years. Will do it. The tools are difficult. The legacy systems that we use all over, including the newer, bigger ones like Epic, are not good on the revenue cycle side. You have to have human intervention at points where you shouldn't have human intervention. You have to have really good follow-up people. You have to have nurse reviewers. Broward Health is structured a little differently than the hospitals I'm used to seeing, in that a lot of that front-end work is done at the hospital system, and I do not believe Janice has any authority or control over them, but Alan has the front-end registration. Most facilities have moved to revenue cycle in the purest sense, where everything that touches the patient from the time they appear is all under one place. But these performance indicators, they have some really good metrics. You have facilities around us that have all done this. We're a little late to the game, but it doesn't mean we're not going to be able to do it. I have confidence that Janice and Alan and their teams will do it. I think they're going to need to engage really closely the CFOs from the hospitals. But it will make a financial difference. When we've implemented this with hospitals, when my company has a hospital this size, you could potentially expect $40 to $50 million in increased revenue. And I'm going to put that pressure on you, Janice. I'm going to ask that we continue to get reports to see that revenue, net revenue growth. But these are something we need to pay attention to, and I'm going to work with Alan to add denial management, which isn't one of these key performance. They're in there. You know they're there. We're gonna make sure they're in there. And I think that as a regular to the finance committee, they'll be reported. I'm gonna ask for them. But to the board, at least in the short term, we might want to report them monthly, just to report a document that says here's the progress we're making. So with that, anybody else have any questions on the revenue cycle side?
You said denial management?
Yeah, so the average hospital in the country, 16% of their claims are denied for various reasons. So there's, it's not denial like, oh no, I didn't do it. It's, it is, they vary. There are codes that insurance companies use. They're supposed to be standard.
CPT codes.
not CTD, these are denial codes, they're called ANSI codes and HART codes. They're definitions of why an insurance company can deny paying you. Every insurance company uses them differently. They were supposed to be used one way, but all insurance companies use them in different ways, which confuses the revenue cycle. If you ever want to drive yourself crazy, go sit in a revenue cycle shop and see what they have to do to figure out. You could have the same exact operation paid for by 3 different insurance companies, and your reimbursement's different for each one based on the contract. They're denial for one reason, medically, clinically, technically. Although in my practice, 90% of the time, it's things that the hospital can control.
I see these on EORs,
Yeah.
insurance companies EOR.
Yeah, and that is, it's a difficult task, but it's not undoable. There are a lot of good systems out there that have done it, and I have confidence that Broward Health will do it as well. Any questions?
Thank you.
Thank you very much. Thank you for keeping on the record.
All right, let's bring George up. Mr. Tomatoes.
Good morning, Commissioners. Good morning, everybody. My name is George Hernandez. I'm the VP of Supply Chain. And I would like to provide an update on some of the key initiatives and accomplishments of the supply chain team in the past 6 months. So 2018 has been a very productive year for supply chain. We have dedicated the past 6 months to make adjustments to align our business models to supply chain and objective with the organizational goals. Some of the accomplishments for supply chain and key initiatives, we were able to deliver $1.2 million in cost savings in the medical supply space, $242,000 in the warehouse relocation, and I will go into details of this initiative later. We conducted an RFP for our medical surgical supply distribution that delivered $1.3 million in savings going forward. And we increased our Vizient GPO share backs by 32%, representing $696,000.
George, do you want to explain what that means? Because that's for the good of the group.
The Vizient share backs?
Yeah.
So we have a contract with Vizient, which is our GPO. So all of our medical supplies and services.
And so you're assuming everybody knows what GPO means, right?
And group versus group.
Assume nothing.
Just maybe assume this.
It's our group purchasing organization. So every organization is aligned with a group purchasing organization. They competitively beat your supplies and services. So we have Vizient as our GPO, previous MedAssets combined with Novation, and now the new name is Vizient.
In short, there are about 6,000 hospitals in the country. There's 3 or 4 GPOs. They buy in bulk, and then they're able to get it cheaper than
Same.
Broward Health would be able to do it themselves.
Costco.
And they have 2,000, I mean, Vizient has what, 2,000?
Around
3,000
members,
hospital members, so they're able to buy a much bigger bulk than us and get us better prices, which of course they're gonna mark up, but it's still gonna be less than we can do it on our own.
That's correct. So our share backs, anything that we purchase on contract over 75 million, we get a percentage of that. And I will go into detail how we have increased the share backs from 2016 over time. So to highlight one of the organizational changes that we made on supply chain, we're hiring supply chain managers at each region. So each facility, region, hospital will have a supply chain manager. In the past, we didn't have a person managing supply chain in the hospital. So this will streamline our supply procurement process. This will maximize our contract utilization. One of the things that I want to mention, we revamped our receiving process at the facility. In the past, we had an 100% auto receipt. So every supply that we were ordering, that we're receiving automatically in the system, and now we're going to a live line. So we have receivers that are actually checking every pallet, every box, counting every single supply, and make sure that if we order 2, we receive 2 or we pay for 2. Before it was 100% auto receive, so all the purchase orders were received automatically in the system. Also, these managers will be looking at consignment contracts at the facilities. They will standardize supplies to reduce inventory levels, and they will help us to achieve contract compliance. All we're doing right now is just building a foundation to move our supply chain to the next level. So we're looking at low-hanging fruits just to build a new foundation in supply chain.
George, do you want to kind of talk about how the material managers at the facilities, contract compliance is not the Vizient, more of a contract that we make with a vendor to make sure that if it's, the contract is for $150,000, that the facility is staying on the $150,000 spend, and there's sort of add a layer of protection to make sure that people aren't going over the PO, so you
Yeah.
kind of talk
So,
about that strategy.
right now we have all of the department managers pretty much trying to track their contracts, their utilization, how much have I spent on this agreement. So our goal is having these managers being the point person at the facility to manage all supplies and services contracts and make sure that they stay within the budget and what it has been approved by the A team of the facility.
And
So
George,
if we
when,
have a contract for $100,000 for a particular service, the managers will be making sure that that particular department stay within that contract, assisting the managers to control the budget.
and George, when did you finally get the final material manager in place?
We still have an opening at BG of Broward General, and we're in the process of recruiting for a manager for that one. We already hired a person for Coral Springs, Imperial Point, and North.
Okay.
And these positions are in place right now. So on the supply chain cost saving projects, the 1.2 million is broken down by GPO, tier maximization, which is basically reviewing all of the GPO's agreement. The GPO, the Group Purchasing Organization Agreement, they have different tiers. So based on your purchasing value, they assign you to a particular tier. So we're looking at every single contract to make sure that our organization is assigned to the right tier and we're maximizing savings that way. So the savings there are 1.2 million. The warehouse relocation, I think that's a great story for the organization. We used to have an off-site warehouse that we successfully relocated to a property of Broward, right behind this wall. So significant savings, the rental, maintenance cost avoidance. We improved the logistical efficiencies and we reduced the touching points. And also we reduced FTEs out by relocating these employees to open positions within the facilities. So we didn't need to lay off anybody. We relocated the staffing to open positions at the facilities.
And George, why don't you talk about how we were kind of double paying for, because we were not using just in time, we were paying for just in time.
So, we were paying our distributor, the markups to distribute the supplies to the off-site locations. When I mean off-site locations, that all of the physician offices, outside, outpatient clinics, we were paying them the markup to deliver the supplies to the offices, and basically they were dropping the supplies in our warehouse, and then we were putting it in our trucks and delivering the supplies to the off-site location. So we were adding touch points and we were paying already for that service. So it's just having conversations with the vendors and start moving directly from the distributors to the off-site locations.
And then talk about in the savings, we didn't really estimate because we weren't sure, we didn't have data to talk about over ordering and supplies that were just kind of aging in the warehouse, which is not any savings. We think that we're going to achieve savings, but we don't.
Yeah, I didn't want to include all of the expired supplies that we have in our warehouse. I mean, not to talk about the condition, you know, the AC, the temperature control. So we did not count, we did not put in here any of those
So
savings.
Vizient does the purchasing from these vendors and then the vendors deliver?
No,
the
we
supplies?
do the purchase from our distributors. We use Vizient contracts. So
Ah.
Vizient is the GPO, we utilize their contracts, but we do the purchase directly with the distributors, and
And
the
then they
distributor delivers to our facilities. It's just in this case, for the off-site locations, and when I mean the off-site location, not the 4 main hospitals, supplies were coming to our warehouse, and then we were putting in our trucks to deliver those supplies.
Those would be like a piggyback contract, sort of where the Vizient contracts with Johnson & Johnson for Band-Aids for 6,000 hospitals. And then we buy based on their contracted price, is that?
That is.
I don't, yes.
They say
it's-
Vizient has a
we're
contract.
picking- so we're gonna do an RFP for a GPO, you know, this year.
Right.
So we basically competitive bid that we're gonna go with GPO contracts. So whenever our GPO has a contracted rate, we're able to use that rate, because it's already been competitively bid.
It's like being a member of an HMO or
Right.
PPO.
Yeah.
I get to take advantage of
And
it.
we just pay them a fee, a markup on,
No.
so they have a contracted rate. How does Vizient get paid?
They get paid from the manufacturer to be on contract.
To be on contract?
Yes. And we get sure backs for participating on that contract with Vizient and increasing our contract compliance.
So what was our budget to staff up with supply chain managers in the individual facilities, what are we spending there? $500,000 overall facilities?
You have four, how many have you?
I'm just, yeah, let's just say 500
We
for.
say $40,
Yeah.
that's pretty good,
Yeah,
pretty good return on it, right?
Yeah, but the material managers in the facility is, you know, that's our protection for the back door, right? Like, so people are making sure that, you know, things are being received, and like, that's kind of my protection, and that's kind of my check and balance to make sure that things are being done properly at the facilities, because I'm not there, and I have to, my job as senior manager is to put, people in place to do well, and that was sort of my thought process. And that's standard. I've never worked in organizations that didn't have directors and material managers, ever. Was any of you? Ever.
So are you seeing a upward trend of savings as people are in place for a couple of months and getting a better handle of what's coming in, what's going out the door, versus better reporting? Okay, so that's good. Good job on that.
I think what's important to note, I mean, I've been here a few years, and one of the things that was very apparent to me was this was not a system. This was a bunch of individual operating units. You know, the supply chain management, the HFMA program, those are all steps in the right direction. We had a very similar situation with supplies, or that you just described with supplies, with prescription drugs, about 2 years ago, where we had expired drugs in one facility that another facility was ordering those exact same drugs. I mean, so I'm just excited to see the progress moving towards actually functioning as a system, and the efficiencies that obviously come out of that. So kudos. I know it's a long journey. There's a lot more steps ahead, but
We have a long way to go.
Commissioner, any other questions, comments? Commissioner?
Yeah, the only other question I had, some of these, I mean, first of all, fantastic job, great work, we love to see millions of dollars in savings. Some of these are reflected as annual recurring savings, other ones say year to date. To what extent are the ones that are not indicated as annual expected to be recurring annual savings, such as the item number 2?
The cost saving projects, those are from looking at supply expense from last May to this May, and looking at the 12-month utilization of those supplies. The warehouse relocation is here today because we did the change in February, so those are the savings achieved. The medical
But that's an
surgical
annual,
distribution.
That's the annual lease,
It will be,
262.
yes.
It's not gonna change next month.
It's not gonna
262 is the annual lease, it's not a year to date.
That's
We'll save $1
continued
million
savings
a year.
moving forward.
But it's every year, but
Yeah.
it's 262 a year, it's not.
The medical surgical supply distribution RFP, those savings will go into effect August 1st and September 1st. So we have two distributors, the primary will go into effect August 1st, and secondary distributor September 1st.
Okay, and that's indicated as a $1.3 million annual savings?
That is correct. And then the increase in Vision GPO share bags, that's the check that we received this month. So the check should be in our inbox, in our bank at any time. And going to the last page, I know we're running out of time. In 2016, we collect insure bags from the GPO, $2 million roughly. Then 2017, an increase of 7.3, going up to 2.1 million. This year, kudos to my team. I have some of my team members here looking at contract compliance and really having one-on-one meetings with the GPO, going over in detail all of our spend and analytics with each of the manufacturers. We were able to increase that to $2.8 billion. That's a 32% increase in 6 months of work. So that's a substantial number.
Fantastic, and who's, at the high level, I mean, who's responsible for overseeing this? Is it the two of you or Alan?
That's my baby.
All right. Great work.
So this is an example of operational efficiency, and it's more what we wanna see in the organization, so. Any other questions?
Guys, I know we're major time, but I wanted just to quickly, George, why don't you just introduce your team very quickly?
I'm going to introduce my team because they have done an amazing work doing all of this. So we have Jose Hernandez, he's our Director of Operations. Responsible for the port security management. Larry Floyd, she's our Manager of Operations and Supply Chain. And Diana Gomez, she's our Manager of the Business Department. We have two other key members, Marcia, our Value Analysis person, but she took a position as a OR Director at BG, and she's really working a a lot in the OR there, so she couldn't make this morning. And then we have Dominic, our director of procurement and sourcing, that she's out of the facilities doing admin services.
Well, you
Thank
deserve a
you.
hand also.